Hello, my name is Joe Becker. I am a faculty member at the Stanford University School of Medicine. I'm here to discuss fever in adults today and a case presentation, how to treat and manage fever in adult patients. And so without further ado, we'll start with the case. This is the case of a 42-year-old male. He recently returned from India, where he previously lived, and he presents with fever for 2 weeks. All right, so we'll start to dissect and break apart this case as we've done with other ones. And as we've done in prior cases, we'll remind ourselves of the emergency medicine approach, which involves, of course, an initial evaluation of the patient, but then sometimes either preferentially thinking and considering and developing a differential diagnosis of the patient, or sometimes there's the need to immediately act and to treat the patient for potentially life-threatening injury or illness. And sometimes this process occurs simultaneously. We have to think and act as we approach these patients. So keep in mind this general approach to emergency medicine patients as we move forward in the discussion. All right, so remembering in our initial assessment of the patient, we want to approach the patient thinking about the general appearance of the patient, their level of consciousness, LOC, and their ABCs, airway, breathing, and circulation. And so here we see that the patient appears to be somewhat confused and diaphoretic, meaning sweaty. We assess their airway, and it is patent. The airway is open. The breathing, although the patient is breathing rapidly, they are breathing effectively, and there does not appear to be any impairment of respiration. We feel for pulses, and we find weak, rapid radial pulses and poor capillary refill. So perhaps there is a little bit of a deficit here with regard to circulation. But as we complete our initial examination, this is essentially what we've been attempting to accomplish, is assess the patient in a very general sense, and then assess for stability by evaluating their airway, breathing, and circulation. All right, and as an important correlate of that process, of course, are the vital signs. And here are the vital signs for our patient here displayed in front of us. As we can see, the heart rate is 124. That's quite high, as we all know. The respiratory rate is 34, and this is also quite high. Blood pressure is 70/48. This is quite low, unfortunately. The patient does have an adequate oxygen saturation of 98% on room air, and they are, of course, febrile at 38.8 degrees Celsius. So with these vital signs, we can start to kind of think about our patient and determine how concerned we are about them, and as well, perhaps start thinking about the things that we would want to do to intervene immediately. So what we've accomplished so far is we have assessed the patient, like I said, in a very general sense, level of consciousness, overall appearance, and their ABCs. We've noted tachycardia, tachypnea, and hypotension. And so as we rank this patient in terms of our impression of their general illness, we'd have to ask ourselves the question of, is this patient sick? Is this patient potentially critically ill? And based on the mental status and as well the vital signs, of course, the answer has to be yes. So this is a patient we want to see immediately and devote our attention to immediately over other concerns in the short term. So how do we do that? We've discussed kind of how to approach the patient and what we see when we evaluate them. And given this instability and given these concerns that we've identified on the physical examination we've performed thus far and the vital signs, what interventions should we undertake immediately to potentially address some of the concerns that we've identified? Well, this is the list of interventions that we sometimes can pursue initially in a patient, and you've seen these in other presentations. Position the patient perhaps on their side if they are vomiting, or in a Trendelenburg position if they're in shock. We can control hemorrhage. We can provide cardiopulmonary respiration. We can defibrillate the patient if they are in a non-perfusing cardiac rhythm. We can open their airway, provide oxygen, provide breaths with bag mask valve respirations, provide cardiac monitor, IV, and blood glucose. In this particular patient, our immediate interventions should involve oxygen, just given the critical nature of the patient's illness. We like to place the patient on a cardiac monitor. Certainly the patient is hypotensive and tachycardic, and so this will be important to do. And we'd like to establish an IV access, and this will be very important because given that this patient is hypotensive, potentially in shock, we would need to establish IV access to be able to provide crystalloids and perhaps other medications of an acute nature. So we put an IV in, and immediately we provide this patient with IV fluids. And of course, the patient is confused. And as we've seen previously, any patient who has any alteration in mental status or seizure or lethargy needs to have a blood sugar checked, because this is an easily correctable but potentially very dangerous diagnosis. All right. So as we consider that emergency medicine approach and what we've accomplished thus far, our general evaluation of the patient, the vital signs, and our immediate interventions, we must think about reevaluating the patient. So at this point, it's appropriate to seek more information. We've established that this patient is very sick and we need to intervene acutely. And now that we've done that, we need to obtain some more information to help us build on that, to help us establish a diagnosis and better drill down on an appropriate treatment strategy for this patient. So the sample history is a very important part of that, and we'll talk about that as well. In addition, a focused physical examination, which is tailored to the medical problem in question. In this case, the patient seems to have confusion and a fever, and so focusing our physical exam on that will be important. As we do that, we'll use that information to develop a differential diagnosis, as we've discussed previously, a list of the potential diagnoses that could be responsible for our patient's condition. Based on that process, we will then act. We will then obtain diagnostic testing to support our thinking, as well as provide treatment to the patient based on what we've discovered thus far. All right. So again, a general approach to how we manage our patients, beginning with the initial assessment, the determination of sick or not sick, the initial interventions based on that determination, and then following that, reevaluation, attempt to obtain more history through the sample history and focused physical exam, development of a differential diagnosis, and then the execution of diagnostic testing or treatment. All right, so this is the approach that we generally take with our patients. So as we've discussed, the sample history is a good mnemonic for obtaining a relatively complete history of a patient who's presenting in an emergency situation. And S stands for symptoms, A, allergies, M, medications, the P is past medical history, L is last meal, which is of course many times important in patients who may have a surgical condition, and then E, or the events surrounding their presentation and their illness. So this is a mnemonic that helps guide us, and as we're kind of taking history from perhaps the patient or their family, we can remember this mnemonic to help us obtain a complete history. So the symptoms in this case, we have a 42-year-old male with fever for 2 weeks and now noted confusion. To explode out a little bit symptoms, we have OPQ-RSTU, which we've seen previously is a mnemonic for obtaining a very in-depth and descriptive evaluation of the patient's symptoms. So O is the onset. So how did this begin? Was it rapid? Was it a very sudden onset, or did this begin gradually, perhaps over hours or days? And in this case, the onset was quite gradual. The provocation, what started this? So was the patient victim of a traumatic injury, or did the patient start a new medication, or did the patient perhaps ingest a substance that they normally did not ingest? Q is the quality. So in this case, it's not really important, the quality of the fever. There is some detail to be gleaned there, but in general, quality may be more descriptive with pain. So for instance, a patient could say the pain is sharp or pressure-like, or it's a dull pain. And so this would be potentially an important piece of information to obtain. R is radiation. Again, not so applicable here, much more applicable in the setting of pain. So if a patient has chest pain, does that pain radiate to their left shoulder? Does it radiate to their jaw or their neck or perhaps their back? That can be helpful in determining or developing a differential diagnosis for the patient's presentation. And then S is severity. So in other words, how bad is the patient's symptom? In this case, the patient's fever seems to be highest in the evenings, and it can be quite high. In this case, 38.8 as we noticed, which can be quite high. And then T, the timing. Of course, we've learned the patient's had this symptom for 2 weeks now. And U, a unifying component of the history. So in this case, the patient just came from India. So perhaps that has some contribution, that piece of information has some contribution to developing a sense for what potential items should be in our differential diagnosis. So we think of the sample history beginning with S for symptoms, and then symptoms can be further detailed into OPQ-RSTU. And this is another mnemonic to help us get even more detailed history. So moving right along through through the sample history, as we explode out symptoms a little more, we see the patient has fever, headache, and then worsening confusion. And now we've noted the patient has abdominal pain. The patient has no allergies. The patient's medications are unknown, except for a recent course of quinine. And the history here that we obtain is that this patient was seen in India, noted to have a fever, and was empirically started on quinine for a diagnosis of potential malaria. It's unknown if any testing was performed to establish that diagnosis. The patient has a past medical history of hypertension, and the patient's last meal was dinner last night. Events, as we've learned, this patient just recently returned from India. All right, so we've attained the sample history, and now we're thinking about a focused physical examination. Well, the focused physical examination is a little bit difficult in this case. In a patient complaining or presenting with a particular complaint like abdominal pain, we can focus our examination based on that complaint. Our patient has fever, and so automatically we would of course assume or want to evaluate for the presence of an infectious illness. And that infection really could be anywhere. And as a result, we're going to have to consider the entire body when we approach the patient. Now, it doesn't mean that we have to perform a full, in-depth physical examination of every particular body and organ system on the patient, but we'll want to at least consider every organ system and potential infections or inflammation that could occur in those organs when we consider the potential causes for this patient's fever. So some good physical examination points that we're going to want to cover is the cardiovascular exam, of course. The respiratory exam is going to be important. The genitourinary exam. The patient is confused and has a history we just learned of a headache, so neurologic examination will be very important. Of course, the patient now seems to have abdominal pain, as we've learned just now in the sample history, so an abdominal examination will be important. And then the HEENT exam will be very important as well to determine if the patient has a head or ENT infection. And then, as we can imagine, skin and soft tissues will be very important to examine. And then finally, the rectal examination. So we'll have to remember all of these components of the physical examination when we approach a patient with really, at this point, still undifferentiated fever to determine, as we kind of cast a wide net to determine if we're able to form a differential diagnosis. All right, so we just mentioned that the rectal examination is an important part of this examination, but it is important also to remember that some parts of the physical exam should not be performed in certain patient groups. So, for instance, patients who are neutropenic or have very, very low white blood cell count, or in other words, an absolute neutrophil count of less than 500, should not have a rectal examination performed, as this is thought to be a risk for seeding the bloodstream with bacteria. Neutropenic patients are, in our world, generally patients who have received some form of chemotherapeutic, but this could also be patients who have very severe either autoimmune disease or bone marrow disease who are not able to mount a normal immune response as would a patient who is not neutropenic. So it's something important to consider in general when we approach these patients. All right, so as we discussed, each part of the physical examination we'll want to consider, and we'll start with the neurologic examination, given that this patient is confused and had a history of an initial headache. We'll want to assess their level of consciousness, as we have. In the initial approach, we saw that the patient was alert but confused. We want to assess their language and their speech. When they speak to us, are they making sense? Are they dysarthric? Do they appear to be aphasic? We'll want to examine their cranial nerves. Do they have cranial nerve dysfunction? We want to examine their motor systems. Is their motor exam symmetric? Is the the upper extremities symmetric with the lower? And does the patient have proximal and distal strength? We'll as well want to assess the cerebellar examination to determine if the patient has good proprioception and position sense. And then finally, of very critical importance in this patient is the meningeal examination. Does this patient have evidence of meningismus? So is there evidence of perhaps meningitis? All right? Now, the sensory examination is also a very important part of the physical exam, but very difficult to do in a patient who is confused and unable to respond to you appropriately. So in this case, we assess the patient. The neurologic exam reveals the patient is alert, but as we've seen, only oriented to his name. The patient does have clear speech, although again confused. The cranial nerve examination is normal, as is really the rest of the focused neurologic examination. The motor exam, the cerebellar exam, and the meningeal examination all appear to be normal. Continuing on the focused physical examination on this patient, we find that the abdominal exam reveals generalized abdominal tenderness. The belly is distended, and there are no bowel sounds. The GU examination, genital urinary examination, is normal. The rectal examination reveals scant gross blood. The ENT examination reveals no jaundice or scleral icterus, no lymphadenopathy, no pharyngeal abnormalities. Cardiovascular exam reveals no murmurs and no pericardial friction rub, which is very important because infections of the cardiac valves, as we'll learn in a moment, are very important consideration in patients who have subacute chronic fevers of unknown origin. The respiratory focused physical examination reveals no rales, no wheezing, or evidence of effusion or consolidation. Evaluation of the skin and soft tissue systems reveals no cellulitis, petechiae, rashes, splinter hemorrhages, which also are signs of cardiac valvular disease, or other evidence of abscess or other potential infectious source. So, our patient is confused, and in confused patients, it can be very easy to miss certain important findings of the physical examination. So in patients who are unconscious or who are unable to communicate fully with the examiner, it's very important to examine the patient from head to toe and to expose them. Patients who, in particular, we do not roll patients and examine their back, we may be missing large areas of cellulitis or perhaps rashes or abscesses that clearly establish the cause of the patient's symptoms. So it'll be very important to examine the back. An often ignored area is, of course, the perineum, the pelvic area is very important to examine as well, as we frequently overlook this, and this, of course, can be the site of other infectious processes that can be very important and easy to miss. Okay, so as we've gotten to the point where we are, we've completed our sample history, our initial assessment, and our focused physical examination, keeping in mind the systems that we discussed. Now, it's important to consider the patient's story. The history is somewhat subacute. The patient's had a fever for 2 weeks. The patient has just returned from India, and this may be important. The ecology of infectious diseases is different regionally all over the planet, and there may be infectious disease considerations in certain areas that are not present in the patient's area of evaluation. So in the hospital the patient's being evaluated in, there may be different local pathogens and even antibiotic resistance patterns. And so these are important to consider. We also need to consider if our patient is immunocompromised. Does this patient have a history of immunocompromising medications such as steroids or perhaps chemotherapeutics? Does this patient have a history of HIV or AIDS? Is this patient a transplant patient? Does this patient have any evidence of immune dysfunction? These are all important things to consider when you approach a patient and you start to build a differential diagnosis of what potential diagnoses could be contributing to their condition. So, following along this same approach, we want to think about very important questions tailored to the issue of fever of unknown origin. So first of all, as we just discussed, the presence of HIV or any other immune deficiency is of course vitally important. This greatly expands the possibilities in terms of pathogens that could be causing the patient's fever. We'd also want to know about their immunization history and status. So is this patient fully immunized? Have they had recent immunizations? Were they immunized for their travel to India? Has the patient had recent travel? And we've learned that the patient has just returned from India. Does the patient have sick contacts? Were there family members in this patient's immediate family circle with similar symptoms? This could, of course, as well suggest the source. What is the patient's occupation? Is this patient a healthcare worker? Is this patient going to be in contact with other sick patients? Does this patient have an occupation that puts them at risk for any particular injury or illness? Along the same lines, does this patient have contact with animals? Many infectious processes are what we call zoonoses, or infections that come from contact with animals. And as such, obtaining a history of this patient's contact with animals in the recent past will be very important as well. We'll also want to know about the patient's recent functional condition. Is this 2 weeks of fever an acute illness, or is this the product of a long dwindling course in which the patient's actually been ill for quite some time? Has the patient had similar illnesses before? Is this coming and going, or is this just a very, very new and abrupt phenomenon? We're also going to want to take a very clear and complete social history. Is this patient a consumer of alcohol? If so, a substantial amount. Does this patient use drugs? If so, does this patient use injection drugs? As you might imagine, these particular historical considerations will, of course, also shed light on other potential diagnoses that could be causing the patient's symptoms. And of course, a very important part of the history that's often neglected is the sexual history. Does this patient have a partner? Does this patient have multiple partners? Does this patient use protection when having sexual intercourse? It is very important to consider these issues, as sexually transmitted infections can be a very important source of fever and severe illness in patients, particularly those returning from travel. Last but not least, does this patient have any foreign bodies, indwelling catheters, or lines? So a dialysis patient might come to you with a line, a central line that they have secured in place, and they may function like this for weeks to months. Other patients have had a joint replacement or other foreign bodies which may be prone to infection, and thus this must be considered as well. So as we gather that information, we have to caution one more time and just remember a few important points. In all patients returning home from travel, the most common cause of fever, particularly in this situation, is a viral infection such as influenza. That doesn't let us off the hook. Certainly our patient's very critically ill, so it doesn't seem like the answer is quite that easy. And even if it is, in an ill patient like this, we are, of course, required to perform further workup to rule out other important diagnoses. It's also very easy to forget that acute HIV infection can cause many of these symptoms. The acute HIV infection can cause rash, can cause high fever, can cause the symptoms of any other acute viral infection, and thus is overlooked. And then lastly, malaria may be mistaken for other diagnoses, particularly if symptoms are not classic. The most common of this is diarrhea. People don't typically think of diarrhea as being a component of malaria infection, and as a result, when travelers return with fever and diarrhea, there is often error made by providers in that we ascribe the patient's symptoms to some kind of gastroenterological pathogen, such as any of the dysentery-causing bacteria, Salmonella, Shigella, Campylobacter, and this can be a fatal mistake if we in fact miss the patient's falciparum malaria. So, in summarizing part one thus far, our initial effort was to immediately evaluate the patient and determine if they were sick or not sick. In this case, we determined the patient was sick, tachycardic, tachypnic, hypotensive, and as well, confused. We then acted on that assessment. So we decided the patient was not sick, and we determined what of the list of initial interventions we should pursue. And in this case, we provided the patient with oxygen, we placed them on a cardiac monitor, and we established IV access and provided them with fluid resuscitation. We then sought to obtain more information through the sample history and a focused physical examination tailored to the possible contributors to this patient's symptoms. So that brings us to this point in the approach to this patient with fever. We'll continue on in a moment with part two. Thank you.